Welcome to another episode from the Veterinary Medicine Digest. Imagine, if you will, the quiet stillness of a Kentucky morning where the mist clings to the rolling hills and the only sound is the rhythmic crunch of hay, until suddenly the peace is shattered by the heavy thud of a 1,000-pound animal hitting the floor of a stall. This is the terrifying reality of an equine seizure, a burst of uncontrolled electrical activity in the brain that can temporarily strip a horse of its motor control, its behavior, and even its consciousness. When these unprovoked events repeat themselves more than 24 hours apart, we enter the complex and often frustrating world of epilepsy, a condition characterized by an enduring predisposition to generate these sudden neural attacks. In the world of veterinary medicine, we often find ourselves looking toward our colleagues in human medicine for a map through the darkness. The International League Against Epilepsy has spent decades refining the terminology and classification of these disorders, moving us away from vague descriptions and toward a rigorous scientific framework. We now understand that an epileptic seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. This excessive activity is essentially an exaggeration of the obligate ion channel activity associated with normal brain function. For a long time, we viewed epilepsy simply as a disorder of abnormal cellular membrane excitability. But the scientific community has recently pushed for a shift in perspective, arguing that epilepsy is better characterized as a disease of the brain rather than just a functional disorder. This distinction is more than just semantic. It conveys a lasting derangement of normal function that demands our respect and serious clinical attention. Under the most recent guidelines, we consider epilepsy to be present if a patient has had at least 2 unprovoked seizures occurring more than 24 hours apart. However, the practical definition has been broadened to include cases where a single unprovoked seizure is paired with a high probability of future events, such as when a structural brain lesion is present. We also recognize that some forms of epilepsy are reflex-based, triggered by specific stimuli like flashing lights, which nevertheless represent an abnormal enduring predisposition. For the equine clinician, the journey toward a diagnosis starts with determining the seizure type, which can be focal, generalized, or of unknown onset. Generalized seizures involve the entire cerebral cortex and result in bilateral motor activity over the whole body. Focal seizures, on the other hand, originate from a localized region of the brain and may result in asymmetrical motor signs or sensations. Interestingly, these focal events can be simple, where mentation remains normal, or complex, where awareness is impaired. Often, a focal seizure can rapidly progress to a generalized event, a phenomenon known as secondary generalization. To truly understand the state of the horse, we must look at etiology, the underlying cause of the electrical storm. We categorize these causes into 6 main groups: structural, genetic, infectious, metabolic, immune, and unknown. A structural etiology implies that an abnormality visible on neuroimaging, such as a tumor or a scar from head trauma, is the likely cause of the seizures. Genetic epilepsy is inferred when seizures are a core symptom of a disorder resulting from a known or presumed genetic mutation. Infectious causes are perhaps the most common worldwide, where the disease results directly from an infection, where seizures are a primary feature. Metabolic epilepsy stems from a well-delineated metabolic defect, such as amino acidopathies or pyridoxine-dependent seizures. We are also seeing a rise in the recognition of immune-mediated epilepsies, which result from autoimmune central nervous system inflammation. Finally, the unknown category remains a sobering reality for many cases where the cause cannot yet be determined despite our best diagnostic efforts. In the high-stakes world of equine neurology, the diagnostic workup is a race against time and technical limitations. While advanced imaging like magnetic resonance imaging is the gold standard for identifying structural abnormalities in small animals, it remains a challenge for the adult equine head. We often rely on computed tomography, which is superior for visualizing bony structures and is particularly useful in cases of head trauma. However, studies have shown that 69% of horses with seizure-like disorders and abnormal brainwave tracings have normal computed tomography scans of the head. This underscores the vital importance of the animal's history, physical examination, and the use of standardized questionnaires and video footage. Clinicians must work to differentiate true seizures from conditions that mimic them, such as syncope, narcolepsy, or even hyperkalemic periodic paralysis. A complete neurologic examination during the interictal period is essential, as the period immediately following a seizure can lead to false anatomic localization. Blood work is a powerful tool, allowing us to identify causes of reactive seizures like hypoglycemia or electrolyte disturbances. Reactive seizures occur when a healthy brain reacts to a temporary systemic disease and are not considered true epilepsy unless they become recurrent. We must also turn our attention to the cerebrospinal fluid, that clear liquid that bathes the central nervous system. Analysis of this fluid is primarily used to rule out infectious conditions like equine protozoal myeloencephalitis or viral encephalitides. Research indicates that pathological findings in the fluid, such as elevated albumin quotients or tau protein levels, are seen in a considerable percentage of epilepsy patients. The albumin quotient is a vital marker, reflecting the integrity of the barrier between the blood and the cerebrospinal fluid. Elevated lactate levels in the fluid may hint at an increase in glucose metabolism during the intense neuronal firing of a seizure. Furthermore, tau protein serves as an in vivo parameter for neuronal destruction and axonal damage. Interestingly, while cell counts in the fluid are often a point of debate, they are only slightly elevated in about 6% of epileptic patients. This suggests that we should not uncritically interpret a high cell count as a mere postictal phenomenon, but rather search for underlying inflammation or infection. The timing of the fluid collection is also critical, as lactate levels and cell counts tend to decline after the first day following a seizure. In contrast, albumin and tau protein levels remain relatively constant for up to 2 weeks. We also find that the severity of these fluid changes often correlates with the duration of the seizure activity. When we focus on the most vulnerable among us, the neonatal foals, the clinical picture becomes even more intense. Seizures in foals are often caused by neonatal septicemia or hypoxic ischemic encephalopathy, commonly known as neonatal maladjustment syndrome. These young animals have a lower seizure threshold and less glycogen storage, making them particularly sensitive to metabolic stresses. One of the most unique and heartbreaking conditions we face is juvenile idiopathic epilepsy in Egyptian Arabian foals. This syndrome typically manifests within the first 2 months of life and is characterized by generalized tonic and clonic motor activity. Affected foals often appear normal between seizures, but the postictal period is frequently marked by a temporary cortical blindness. While a genetic cause is strongly suspected, it has not yet been confirmed, and recent research suggests it may be a complex polygenic condition. The good news is that this form of epilepsy appears to be self-limiting, with most foals becoming seizure-free by 1 year of age. Management of these foals requires constant vigilance, with padded stalls and headgear to prevent secondary trauma. Control of acute seizures in the neonate has historically relied on intravenous boluses of diazepam. While effective for immediate control, diazepam is short-acting, and its clearance is slower in very young foals. This has led many neonatologists to turn toward midazolam, a potent short-acting benzodiazepine. Midazolam can be administered as an intravenous bolus or as a continuous rate infusion, allowing for smooth and rapid control. One of its greatest advantages is the ability to readily assess the foal's neurologic function once the infusion is stopped. This stands in sharp contrast to the use of phenobarbital, which often leaves foals in a stuporous state for days, complicating their management. Phenobarbital can also cause significant respiratory depression and affects blood pressure and thermoregulation. Despite these drawbacks, phenobarbital has long been the drug of choice for the long-term management of seizures in adult horses. The science of pharmacology in the horse is a lesson in species-specific differences. Phenobarbital clearance is remarkably high in horses compared to humans or dogs. This high clearance rate explains why the drug has such a short half-life in horses, ranging from about 6 to 17 hours. To maintain therapeutic levels, a maintenance dose of approximately 6.65 milligrams per kilogram every 12 hours is often recommended. Because rapid administration can lead to heavy sedation, the drug should be infused slowly over 20 minutes. When phenobarbital alone is not enough, potassium bromide is often added to the regimen. Potassium bromide is not metabolized in the liver, making it a safer option for horses with liver disease. However, it has its own set of toxicities, including tetraparesis and ataxia, and owners must be cautioned to wear gloves during its administration. We are also seeing the emergence of levetiracetam as a promising new tool in our arsenal. Levetiracetam is structurally unrelated to other anti-epileptic drugs and has a very wide safety margin. It targets high-voltage calcium channels and synaptic vesicle proteins to stabilize neuronal activity. Recent studies in healthy adult horses show that levetiracetam has a high bioavailability of over 90% after oral administration. Its terminal half-life in horses is about 6 to 7 hours, which is comparable to that found in humans. A recommended dosing regimen of 32 milligrams per kilogram every 12 hours is likely to maintain effective plasma concentrations. This drug is well tolerated, with only minor adverse effects like yawning or transient lower head carriage observed. The fact that food does not affect its absorption is a significant advantage for the equine clinician. As we look toward the future of epilepsy management, we find ourselves exploring the profound link between cellular metabolism and neuronal stability. For nearly a century, we have known that a high-fat, low-carbohydrate ketogenic diet can reduce seizures when drugs fail. Recent evidence suggests that this metabolic therapy does more than just arrest seizures. It may actually prevent or reverse the progression of the disease. By altering the body's primary fuel source from glucose to ketone bodies, we seem to enable a homeostatic state in the brain that is less excitable. This metabolic shift raises the threshold for seizure generation and makes the central nervous system more resilient to stress. Ketone bodies like beta-hydroxybutyrate are not just alternative energy sources, they have pleiotropic properties that interact with multiple molecular targets. Studies have shown that a ketogenic diet can increase the levels of gamma-aminobutyric acid, a key inhibitory neurotransmitter. It also appears to promote the activation of inhibitory adenosine receptors, which hyperpolarize and stabilize cellular membranes. Perhaps most intriguingly, this metabolic approach may have epigenetic effects, leading to a permanent reduction in seizure risk. While implementing a strict ketogenic diet in horses presents obvious practical challenges, the research into metabolic therapy is expanding. We are investigating supplements and analogous approaches that might mirror the mechanisms of the diet without the same restrictions. We now recognize that metabolic dysfunction is a common thread in many neurological disorders, where seizures are often just one symptom of a deeper pathology. Seizures can be seen as the canary in the coal mine, a sporadic expression of a brain struggling to maintain its functional balance. By providing metabolic support at the mitochondrial level, we can improve the overall metabolic health of the brain. Promoting stability and resilience is key, as we know that factors like dehydration, sleep deprivation, and stress can shift the delicate balance towards seizure generation. The unparalleled success of metabolic therapy in treatment-resistant cases highlights the power of a multifaceted buffer against excitability. While the exact triggers that push a network into a seizure remain unknown, we can reduce the probability by optimizing the metabolic landscape. This stable metabolic phenotype is the foundation for normal brain function and a significant step away from the unpredictable world of sporadic seizures. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.